So we continue to talk about the digestive system, and I'm getting all pumped up. I want to go through the mouth and pharynx and get to stomach. That's where the fun stuff begins. But let's talk about salivary glands first. Okay? So salivary glands produce saliva, which contains two types of secretions, and I want to remind you, in the human organism, we have two big types of secretions. We have mucus secretion and we have serous secretion. So serous is watery. We talked about structures like peritoneum, right, before. That's watery secretion. Mucus secretion, on the contrary, contains a lot of proteins, especially protein mucin. So saliva contains, first and foremost, water. We produce 1 to 1.5 liters of saliva a day. Water is an essential component here. Why do you feel the taste of food? If you would lick this table, would you really sense the taste of a table? Not really. You would sense the taste of whatever's on the table, or the dust and dirt. To feel the taste, you need your saliva to dissolve the chemicals that are contained in the food. Does that make sense? Then, you need your saliva to clean teeth. It's actually extremely effective. The constant washing of your teeth in saliva, it keeps them more or less clean. When you chew the gum, it makes your teeth clean for two reasons. One, all the crap sticks to the gum, and second, you salivate. That saliva washes your teeth around. Electrolytes, yeah, mucin. Mucin is a protein, or the protein. It is an essential component and the key component of mucus. Mucin is sticky, it's like glue. So it allows you to form so-called bolus of food. If you go fishing and all you have, you can go fishing with a piece of bread, okay? Pretty much all you need to do is to chew a little bit on the bread to make it wet and sticky. And then you can roll the little ball out of it, okay? And it can be a bait. So it makes it sticky. Lysozyme is the broad spectrum antibacterial protein that can be found in many mucus and serous secretions around the human body, from saliva to nasal secretions to tears. Immunoglobulin A, all you need to know about it, we didn't talk about immunoglobulins. This is the class of proteins that are produced in response to various infections. Not only bacterial, viral, kinds of infections. And they confer one of the first levels, one of the first layers of defense against pathogens. So far, if we would group, we have water that dissolves the food chemicals, we have mucin that makes the food sticky, and we have lysozyme and immunoglobulin A, which protect. And finally, saliva is an important digestive liquid. It contains two enzymes, salivary amylase and lingual lipase. Lipase, what does it do? What do you think? Breaks down what? Lipids, yes, breaks down fats. And amylase, bless you, carbs, yes. So salivary amylase breaks down carbs. You can check that you have one, salivary amylase, if you would chew on the bread, if you chew for a longer period of time, you will feel the sweet taste in your mouth. That comes from salivary amylase breaking down carbohydrates, starch in the bread, breaks it down to glucose. Does that make sense? You have to spend considerable amount of time chewing the same piece of bread. So saliva helps you to digest fats and carbohydrates. Does that make sense? So what produces saliva? There are two major types of glands, intrinsic and extrinsic. Intrinsic or unicellular salivary glands can be found in the cheeks, in the inner surface of lips, and on your tongue. So buccal, cheeks, lingual, tongue, and labial lips. These glands, they produce lingual lipase. That's where the fat-breaking enzyme comes from. Extrinsic salivary glands are big. They're multicellular. They're large. Parotid is the largest extrinsic salivary gland that produces, kind of surprisingly, only about a quarter of saliva. Submandibular salivary gland produces the majority of salivary secretion, 60 to 70%, and sublingual produces fairly small amount of saliva. These large glands, the extrinsic glands, are connected to the oral cavity by the ducts. Okay, duct, general, is the tubular structure that drains fluids. Okay, so we mentioned before that digestive activities are controlled via reflexes. Remind me, please, what type of reflexes we're talking about here? Somatic or autonomic? Autonomic reflexes, that's right. So your autonomic nervous system can be, the motor component of autonomic nervous system can be divided into two branches. Do you remember? Parasympathetic and sympathetic. Parasympathetic and sympathetic. Correct? So which one is fight or flight? Sympathetic. Sympathetic is fight or flight. Anything related to excitation, excitement, fear, exercise, activity is sympathetic. Parasympathetic is rest and digest. So overall, practically all digestive activities are stimulated by parasympathetic nervous system. Does it make sense? It's kind of easy because you can think, okay, parasympathetic will stimulate any sort of digestion, and that's true. Salivation is not an exemption. It's all the same. So what will trigger, what will initiate, what kind of sensory input will start salivation reflex? Anything related, smell of food, taste, just presence of food in your mouth. Does that make sense? Even if you would take, if you would start to chew on anything, not necessarily food, just mechanical movements will stimulate salivation. So essentially what happens is the presence of food in the mouth, that sensation will be delivered through either facial or glossopharyngeal nerve, okay, to the integration center, salivation center in the medulla oblongata. Now please know where the salivation center is, okay, that's medulla. And then medulla will produce a response via submandibular ganglion, again facial nerve, towards the salivary glands. Does that make sense? Do you understand the sequence? You have sensory input, which is food in your mouth. Signal is delivered by the afferent fibers to the medulla. Medulla produces the response, which is delivered by efferent fibers to the salivary glands. Salivary glands, in this case, play as the effector of the parasympathetic system. Does that make sense? Any questions? Now, when you say, I just had my snack, afternoon snack, seriously, I just had it. So, I still have a taste of food in my mouth, still have increased salivation. When you are scared or nervous, what happens to the thickness of your saliva? It's thicker, it's more dense. An explanation is really elegant and simple. When you're nervous, what kind of system becomes activated? Sympathetic. Sympathetic system, along with other effects, constricts unnecessary blood vessels. In case of fight or flight reaction, nervousness, stress, blood vessels that run through the salivary gland, you can see the blood vessels here, blood vessels that run through the salivary glands, they are definitely not essential. So they become constricted. So the amount of blood that goes through the saliva goes down. And essentially, the main source of water for saliva is blood. Does that make sense here? Less blood, less water, saliva becomes more concentrated, it becomes thicker. That's it. Now, before we move to perioditis, I want to ask you, so I try to make clinical connections whenever possible. This is one of those. Have you heard about the condition called head and neck cancer? I learned it, I for a long time didn't know. Turns out in medical field, to say there's like brain tumor, right? And well, brain tumor is separate, but tumors of, say, nose, mouth, throat, everything that's in the neck or in the head, except the brain tissue, like tumors of the lips, for instance, tongue, they're all sort of treated by the same team of doctors. I do not know the medical reasons for it. They either sarcomas or carcinomas, you know, that's pretty much it. But it's like it's a specialty, head and neck tumors. And it's quite fascinating, really. It's interesting. Well, I had a chance to see the talk by a person who studies head and neck tumors. Actually, like surgeon, okay? And he showed pictures of patients before, which I don't want to sound, I probably will sound condescending, but my only question, you know, if you have something of that size on your face, you probably should have come to the doctor earlier than that. Because that didn't develop overnight. If it's the size of a large apple, you probably should have noticed it before. Of course, there are smaller tumors of the lips, palate, throat that are hard to spot. But it wasn't the only thing. And one of the major treatment options in case of head and neck tumor is the surgery. Tumor is removed. Often it is removed with a part of a bone, which is, when you see what plastic surgeons can do now, it's incredible. You know, they can pretty much, half of the jawbone is removed and then they replace it with like a plastic or whatever material they use, and the only problem remains is skin. That was pretty much a topic of that seminar that I went to, how to transplant the skin and problems associated with that. But what I'm kind of leading towards is sometimes salivary glands have to be removed. Some of them or large portions of them. So what do you think happens to people who lose a significant part of their capacity to produce saliva? What are the day-to-day consequences? Dry mouth. So that's one. Horrible caries. Their teeth aren't clean. They have horrible caries, dental caries. And that's, well, bad breath and all that kind of stuff. And also problems with taste. They don't have enough. Oh, and people who lose a large portion of salivary glands, they have another interesting problem. It's not fun at all. They can hardly swallow food because they can't form that tight bolus that they can push then into the throat. It's all separated into chunks and it's really hard to swallow. Does that make sense? Now, inflammation of salivary glands, mainly parotid gland, is called parotitis. Also called mumps. The virus is called mumps. Back home, the condition when somebody has mumps virus, mumps infection, and develops this largely swollen, inflamed salivary glands, sort of an official name, literal translation is piggy face. It's not life-threatening, really. Fever, that's about it. Fever. Okay. We have a vaccine now. At some point, practically every kid had parotitis, but we have a very effective vaccine. Yeah, I shouldn't say very effective vaccine. It's decent. That prevents this infection. And if you think about it, it's not life-threatening. So if you acquire it, you can say, oh, whatever. However, in males, it's one of the leading causes of infertility. It's a leading infectious cause of infertility. Causes inflammation of testes or chitis, and either inflammation eventually destroys the reproductive capacity of testes because of formation of the scar tissue, or sometimes they have to be removed if it's really severe, and so on and so forth. So the vaccine, it does not cause autism. I don't want to get into it, but it doesn't. So just do it. Preferably multiple times, because it turns out the vaccine that we have is not the best. It's about 85% effective. So multiple boosters will give you good protection. I mean, it causes some complications in the females as well, like oophorytis, inflammation of ovaries. It may be very, very severe in people with impaired immunity, but in otherwise healthy patients, it's pretty mild. Any questions? So teeth. Let's talk about the structure of the tooth first. There's three parts: crown above the gum, neck inside the gum, and root among the alveolar processes of the jaws. Does that make sense? So this is alveolar process, this is alveolar process, and between them is a tooth. The top of the tooth, the crown of a tooth, is covered by enamel. Did I say it right? Thank God. I learned how to say it after 12 years in the United States. It's the hardest compound found in the human body. It's harder than bones. Okay. Under the enamel is dentin. It's softer. It's like bone-like. Okay. It's not as hard. You don't take it that it's like soft. It's still hard. It's not enamel, but it's still hard. And under dentin is the pulp. Pulp fills up the root canal. Okay? So root canal, here, it's root canal. It contains blood vessels and nerves, and when it becomes inflamed, it hurts. Because that inflammation, during the inflammation, all the chemicals, inflammatory chemicals that are produced, they act on the nerve endings. Here, the yellow stuff, okay, they act on those nerve endings, causing pain, constant pain. So when you go to the doctor that treats root canal, not only, well, they drill into the tooth and they destroy the nerve inside to kill it so it doesn't feel pain anymore. The downside of the root canal treatment is that in the absence of innervation and in the absence of blood supply, the denervated tooth, essentially a dead one, starts to degrade, should I say slowly? So eventually it just falls apart. So the person who's close to losing about a third of his teeth, I know what it is. I had quite a few root canals and most of those teeth are gone by now. Okay? So it's when doctors tell you it's a good idea to put a crown on it, it is a good idea to put a crown on it. It prevents it from destruction. The tooth, when it is in the jaw, when it's healthy, it's attached by periodontal ligament to the bone. Okay, so it's a unique joint actually called gymphosis. Okay, periodontal ligament carries the tooth pretty well, holds it to the jaw. That is why it is really hard to pull the tooth out, especially if we talk about bigger ones like molars. And it's hard to knock the tooth out. When people say the tooth was knocked out, usually what happens, it breaks the neck right here, but the root stays in. And in fact, if that happens to you, if you manage to find the crown of a tooth, doctors can install it back on the pin. The reason why I have so much experience with that, I knocked my tooth out in the true sense when I was 8. I fell and it went out with the root. Doctors were shocked, really. They also said that I was ugly. Now, types of the tooth. Gum, dense, irregular connective tissue. It's covered on top. Let me show you where. So the thick of a gum is dense, irregular connective tissue, but here the surface is covered by stratified squamous epithelium. Can you tell me why stratified squamous? Friction, yeah, abrasion forces, constant friction from the food. It has to be able to lose the layers. That make sense? Now, types of the tooth. We have 20 deciduous, which are temporary, and 32 permanent. Tooth can be, so among the deciduous teeth, we have 4 incisors. Sharp teeth, 4 on the top jaw, the upper jaw, 4 on the bottom jaw. They cut through the foot. That's why you can bite. We have canine, which is necessary to rip or tear the foot. And we have 2 molars, which are necessary for grinding and crushing the foot. Deciduous teeth appear usually around 6 months of age. As I mentioned before, I try to ask as little numbers as possible. So only 2 numbers that you have to know now is 20 and 32. 20 deciduous, 32 permanent. Yes, they appear around 6 months of age, but there are examples of it's absolutely normal for an infant to be born with some teeth. Okay? And they replaced with permanent teeth. It may take different amount of time. Some people have all the deciduous teeth gone by the age of 9, 10. Some still have several lingering on after that. I'm not going to test you on, when. What you do have to know is that among permanent teeth, we have some modifications. We still have those 4 incisors, okay? We still have a canine, but then we have what is called premolars. 2 premolars on each side of each jaw, so 8 total. Premolars are absent among deciduous teeth. They can be found only among permanent. And premolars, along with molars, comprise teeth that we use for grinding and crushing food. The wisdom tooth, not every person will have them. They don't pop in every person. In some people they are out, in some people they're not, and sometimes they aren't even functional because they can be barely out of the gum. Okay? So basically, know these numbers, 20 and 32, know which ones are absent in deciduous, and know the function of the teeth. Of course, I expect you to know the cross-sectional structure of a typical tooth. Good? Now, pharynx or throat. So this is pharynx. On this image, it's highlighted with purple. That makes sense? No, I don't have a head around me, but you can see it there. So highlighted with purple. Also call it a throat. It starts from nasal cavity, okay, and it extends all the way down from nasal cavity to the larynx, okay. It is posterior to the oral cavity, which is shown here in red, and can be divided into 3 parts. Nasopharynx, which is basically up here. Oropharynx, the part of the throat posterior to the oral cavity. And laryngopharynx, the part of a throat immediately superior to larynx. So essentially a nasopharynx, oropharynx, and laryngopharynx. Nasopharynx, which runs from the nasal cavity to oropharynx, participates only in respiration. Oropharynx and laryngopharynx, these two, participate both in digestion and respiration. By digestion, I mean swallowing, deglutition. Does that make sense? So I'm going to tell you that some of the parts, the oropharynx, some of the parts of pharynx are covered with stratified squamous epithelium, and some parts are covered with simple squamous epithelium. Which ones are covered with which? Nasal simple, laryngo. Exactly. And oral and laryngopharynx are covered with stratified squamous. Do you understand the necessity for it? When we swallow, food rubs against the epithelium. And in the places where with substantial abrasion forces, there is stratified squamous epithelium, you're going to lose those cell layers over and over again. Does that make sense? Good. Now, we're going to be talking about another reflex. Deglutition reflex, swallowing reflex. This is here. It's the bolus of food in your oral cavity. You push that bolus of food using your tongue towards the pharynx. When you do that, when you start swallowing, is that a voluntary move? Yes, yes. You start swallowing absolutely voluntary. Does that make sense? Trigeminal nerve, which is largely sensory nerve, sends the signal again to the medulla oblongata. Okay. Medulla produces the motor output via the glossopharyngeal nerve towards the throat. Okay. Stimulating muscles that this time involuntarily propel the food through the oro and laryngopharynx towards esophagus. Let me see if I can get half of the head right here. No, I'm sorry. No, we're good. So if you would look at this gentleman right here, this head. So this is oral cavity, right? The food voluntarily pushed towards oropharynx, voluntarily. Once it crosses that border between oropharynx and oral cavity, enters the oropharynx, the movement becomes involuntary. Once it gets into the pharynx, that's it. Once the food is oropharynx, that's it. You can't control it. It's going to go down involuntarily. Does that make sense? And the reflex arch is stretch in your posterior oral cavity because of the bolus of food. Signal goes to the medulla. Medulla generates the response to propel the food down towards esophagus. We have two problems. Problem number one, your oropharynx is connected to your nasopharynx. Problem number two, your laryngopharynx is connected to the larynx, which is then connected to a trachea. So how can you make sure that food, when it enters oropharynx, doesn't end up in your nose or your trachea? The small structure that we talked about already, called uvula. Okay, it's completely off. This labeling, this uvula labeling is like completely off on the picture. But uvula, you can see it in the mirror. You can open your mouth and see that little thing hanging from the soft polati in the back. That's uvula. When medulla oblongata sends the signal to swallow, uvula closes nasopharynx. Does that make sense? At the same time, epiglottis, which is not off, surprisingly, epiglottis closes larynx, so food doesn't get into the trachea, into the larynx and trachea. Does that make sense? So both respiratory passages are closed, they're blocked. That's why when you swallow, you can't really speak. Does that make sense? You may know, when, what's the word for it? When you get food in your respiratory tract, Like, yeah, when you aspirate food, I thought there would be some common name for it we use on day-to-day basis. But yeah, when you aspirate the food in the respiratory tract, that can be because you try to inhale at the same time you eat, or you shake yourself. Like you eat when you, I don't know, riding a horse, for instance. Also, when you laugh, when you eat, what's laughing? Laughing is an expulsion of air at a large speed. So essentially, you forcefully push the food that may be in your mouth or in your pharynx through the uvula. Cannot help it anymore because it's so powerful. It'll end up in your nasal cavity. It'll go through nasopharynx. But normally, when you swallow, uvula closes the nasopharynx and epiglottis closes larynx. So kind of to go through that again in the image, you have a bolus of food that is propelled towards oropharynx, that stretch, okay, sends the signal to the medulla oblongata that generates the involuntary response and peristaltically propels the food through the oro and laryngopharynx towards the esophagus. At this time, uvula closes nasopharynx and epiglottis closes respiratory passages. When food approaches the esophageal sphincter opens and lets the food through, then it closes, and the bolus of food ends up in the esophagus. Does this sequence make sense? I will ask you about this sequence, I promise. Really, there's going to be a question when you have to pick the right order of events in the deglutition reflex. So please understand, we swallow first, signal goes to medulla, medulla closes uvula and epiglottis, and then opens sphincter, food gets through the sphincter into the esophagus. Everybody understands what the sphincter is. Circular muscle. It can consist of the smooth muscle or skeletal muscle. Good? So, since we are about to move towards esophagus, let's see a few things. So when food gets in the esophagus does peristalsis. There's two layers of smooth muscle, circular and longitudinal. And it'll just, like you squeeze the toothpaste out of the tube, it will squeeze the food towards the stomach. Does that make sense? Okay. So, stomach and esophagus are separated by so-called gastroesophageal sphincter. When food approaches, there's a stretch right here. There's a local reflex opening gastroesophageal sphincter, and the bolus of food enters the stomach. Does that make sense? This presence of sphincters really allows your digestive system to precisely control the movement of the food through it. Does that make sense? Now think about this, like food is in your stomach. We're kind of running a little bit ahead of a train, but it makes sense. Food is in your esophagus. Food is being pushed downwards towards the stomach. It still, nothing technically prevents it from moving up, except for the sphincter that is closed. Does that make sense? The food is in the stomach. You can jump all you want. It's not going to pull up, well, unless the sphincter is open, and generally it's not. However, in children, it's interesting detail. In children, especially the smaller they are, the easier it is for them to involuntarily reject food. You just, put them upside down, and it kind of it's practically going to drain out of them, because they don't have that reflex control over the sphincters yet. It's practically like a bottle. Okay, you turn them around, and whatever's in the stomach is going to get right out. Okay, and it may last for quite a long time. I mean, I did experiment with my nephew when he was like 4 or 5, and I pulled him up and said, can you put me in a normal position, please? I'm about to vomit. So I put him in the normal position, and he keeps playing. He's fine. So just because of upside down thing. Does that make sense? So in adults, it's all good. Questions? Esophagus is kind of boring, really. Nothing of a particular interest. Few things. Normally, it's collapsed. And as a general rule of thumb, if you have a muscular tube, really muscular tube, if nothing feels it, it's going to collapse. It's normal. So when there is no food in the esophagus, you can see that the lumen of esophagus is pretty small. It's stretchable, but it's still pretty small. So esophagus merges stomach at the cardiac or cardial orifice. You understand the word orifice? Opening. Okay. Esophagus does go through diaphragm. Stomach is below the diaphragm. What should I say? Yeah, there's a sphincter, and that sphincter is really important because it prevents stomach content from going back into the esophagus. We'll talk about this condition for a little bit. Now, mucosa. The mucosal layer is stratified squamous epithelium. For same exact reason we just discussed, rubbing forces. In the submucosa, esophageal glands produce lubrication to help food to move down towards the stomach. And there are 2 layers of smooth muscle. Well, it's not only smooth muscle, okay? So the muscularis externa that surrounds esophagus is the mixture of smooth and skeletal. The upper third is skeletal, and middle is mixed, and the lower third is entirely smooth. So there's a transition. You have skeletal muscle that surrounds your throat, helping you to swallow voluntarily, and then it kind of is substituted. Not kind of, it is substituted by the smooth muscle. Does that make sense? It doesn't have serous layer on the outside. It doesn't have serosa. Instead, it has adventitia. It helps to attach esophagus to other structures. Now, if you think about it, think about the thoracic cavity. There's not a lot of organs that freely move around. Does that make sense? Lungs, confined in pleural cavity. Heart, confined in pericardium. Thymus, confined in superior mediastinum. There's not a lot of things to rub against, so there's no need to have cirrhosis. Any questions? There's not really any specific reflex involved. So, well, we can talk about gastroesophageal sphincter now. One of the dysfunctions of gastroesophageal sphincter is the heartburn, right? When it doesn't close completely, then the stomach content can enter esophagus, and since esophageal epithelium is not suited for that type of exposure, let's put it this way, doesn't like acid, you feel that burning sensation. Obviously, the name heartburn People thought that something wrong with their heart, not necessarily in this case, but that stuck. Well, there are two reasons. One, when acidity is really high, and on top of it, the sphincter doesn't close completely. So even just a little bit will cause that burning sensation. Treatment is the antacids, and there are drugs that help to establish proper control of the gastroesophageal sphincter better, but mostly antacids. One may say, okay, heartburn is unpleasant, but why do I care? When the epithelial tissue in the esophagus that is not supposed to be exposed to the acid is exposed to the acid, what's going to happen to that epithelial tissue? It's going to die, yeah. It's going to die. It's going to get destroyed much faster than it's supposed to be, you know. So that is an injury. Injury always leads to eventually inflammation and scarring. Yes. Scarring wouldn't be the issue here because connective tissue would replace itself. You're not going to burn your esophagus all the way down to smooth muscle. So it's going to be connective, it's going to be epithelial, but the problem is that it's going to be constant inflammation. Inflammation means repair. That's the role. That's why inflammation is important. Repair means cells dividing and dividing and dividing. And the more cells divide, the higher the chance to accumulate mutations. More mutations, more chances to develop cancer. And it was shown that there is an association between the chronic heartburn, untreated, I have to highlight, untreated chronic heartburn and esophageal cancer. It's not, of course, the only cause by any means. Another great risk factor for esophageal cancer is smoking. But the acid reflux is a legitimate, cause to worry and to visit a physician. Does that make sense? Finally, something meaningful. I mean, not that you can live without esophagus, but stomach is kind of cool. So it's a bag. It's a huge, not so huge, but bag. This bag, the stomach, can be separated into a few regions. Cardia, first and foremost. Cardia, what does that mean? If we kind of step away from stomach and just think about the word cardia. Heart, fairly close to the heart. It's not a heart, but just name stuck again. So cardia is the part that is where the food comes from esophagus. That's basically it. That's it. Okay? Then we have fundus, the body. Those are two parts of the stomach where digestion, like real digestion, occurs. Does that make sense? And then we have a huge part that is called pylorus. Pylorus can be divided into the pyloric antrum, and antrum in this case means entrance. So pyloric antrum is the connection between the body of the stomach, okay, and something down there. And then pyloric canal. Pyloric canal channels food from pyloric antrum towards the pyloric sphincter. So again, this is the antrum, right? This is pyloric canal. And this is sphincter, another ring-shaped muscle. Now, pyloric sphincter separates stomach and duodenum. That makes sense? So when pyloric sphincter is constricted, completely constricted, can food pass from stomach to intestine? It cannot. So to pass, it has to open. Am I clear? I want you, I'm not going to ask like today, okay, we're just going to have like a pop quiz. Here's the questions, come on, answer. What I wanted to say, oh God. Oh, I want you to keep in mind that we have that separation in the stomach. We have cardia, we have fundus, we have body, and we have pylorus. Just keep it in mind. Anatomically, like if you would just look at the gross anatomy of a stomach, you wouldn't be able to draw a line saying cardia ends here. But there are microanatomical and functional differences that we're going to talk about that allows them to stand out. Does that make sense? Now, as many other whole organs, when stomach is not full, it is collapsed. And its walls, when it's not full, it's empty, walls form rugae, like folds, okay? Ridges and crevices. Does that make sense? Considering this picture here, this picture is wrong, technically. Why? Huh? And it's what? It's distended. Not only this, it's distended, but still has rugae. You see? It probably was not intentional mistake, but it's pretty common. In basically every textbook, you will see a picture like that, and I completely understand why. Because you have to show the shape, and you have to show rugae. And in fact, if you would look at the empty stomach in the cadaver, fortunately I don't have that image, but I'll check. I may have some cadaver images. It's flat, really. Does that make sense? Good? Now, the wall structure. Mucosa. 4 basic layers, mucosa. Simple columnar epithelium. Under that simple columnar epithelium, lamina propria. Okay? And then thin layer of muscularis mucosa, as usual. Then there is a submucosa, which is connective tissue with blood vessels and nerve endings. There's a huge submucosal plexus. And then muscularis externa, which in the stomach has 3 layers, not 2. It has circular layer, it has longitudinal layer, and it has oblique. So these 3 layers of smooth muscles allow stomach to very intensively move the food around. It's called gastric churning. Talk about it. So the food is churned. Vigorous mechanical digestion. Does that make sense? And of course on the outside you're going to see the serous layer, serosa, which produces watery secretion, for lubrication and protection of the stomach. Questions before we move on? We're good? So let's talk about the epithelium. And cells that can be found in the stomach epithelium. So here on the left, you can see the typical fragment of the mucosal layer in the stomach. You can see lamina propria, and these are columnar cells. You can also see that the surface of the stomach isn't flat. It has pits, so-called gastric pits or gastric glands. So this is a gland. Does it make sense? So each gland like this, each structure like this one, it produces different types of secretions. We can call them gastric juice. So far, do I make sense? So let's figure out what's going on here. Okay, what these cells produce. First and foremost, what is the pH in the stomach? Acidic. And the food is moving a lot. And I believe everybody vomited in their life at least once. You know that stomach content still has, pretty decent chunks of food. That makes sense. So there's a lot of movement, there's a lot of chemicals, and mucus cells, goblet cells, essentially goblet cells. We can call them mucus cells as well. You can see mucus cells. They produce thick alkaline mucus. Alkaline, why? To neutralize, to offset the effects of stomach acid. You can't really neutralize. You don't want to neutralize it, don't get me wrong. Because if you neutralize it, you won't be able to digest. But to offset the effects of stomach acid on other cells. Why thick? Why really dense? There's food moving around. One thick, dense layer. Protective layer, like a lubrication, so food doesn't scratch that much against the epithelium. That makes sense. Nevertheless, and those cells, they are connected by the tight junctions, so acid doesn't spill into lamina propria. That makes sense. Now, if you think that your stomach epithelium is well protected, well, think twice, because cells in the stomach they live for about 5-6 days, and then they replaced. There are stem cells in the gastric glands that constantly produce new cells of columnar epithelium, because those cells still die pretty regularly. Okay, this is one of the reasons why different therapeutic approaches, like say when people receive anti-leukemia therapy, one of the things that is targeted immediately is digestive tract. Side effects like vomiting and different sorts of indigestion come from the fact that when cancer cells are targeted and they fast dividing cells, other fast dividing cells being killed as well. And first and foremost, cells of the stomach and intestinal epithelium. Pretty much people being stripped of their epithelium. That makes sense. Now, parietal cells is shown here in blue. You can see parietal cells here. They very differentiated. Do you understand the word differentiated? They're very specialized, extremely specialized. The function, bless you, the function of parietal cells to produce hydrochloric acid. That makes sense. That's not it, but to a large extent. Okay. Hydrochloric acid is crucially important as the catalyst for the protein breakdown. It kills microorganisms, it denatures proteins, and all kinds of stuff. Breakdown of everything requires either acid or base. I'm telling you that as a chemist in the past. acid or base, they work as a catalyst in nucleophilic substitution. Okay. Also, they produce so-called intrinsic factor. It's a protein that's necessary for the B12 absorption, vitamin B12. Vitamin B12 is a very interesting vitamin. First of all, it's a biochemistry student nightmare. If you have an instructor that requires to memorize a formula, it's probably easier to just quit. It's gigantic. It's gigantic organic compound, enormous organic compound. And it is necessary for so-called factor for some enzymes that participate in cell division. So essentially, people with B12 deficiency, the first symptom is anemia, so-called pernicious anemia. Since their red blood cells, well, the bone marrow cells cannot divide effectively, their red blood cells levels go down and they have anemia. Does that make sense? So, an interesting thing that some people with certain people who are deficient in intrinsic factor cannot take vitamin B12. And that was found, it was a very interesting experiment. So there were people who suffered from pernicious anemia, and they were given large amounts of vitamin B12. And it didn't help, because they did not have intrinsic factor. And then somebody thought, okay, what if it's a component of their stomach? So what they've done, they mixed vitamin B12 and pretty much the extract of the cow's stomach, which contained intrinsic factor itself, and it worked just good enough to help them out. Does that make sense? So you can, if you don't have intrinsic factor, vitamin B12 by itself is not going to do any good. It's going to pass through. Does that make sense? So that's parietal cells. Now chief cells produce the enzyme called pepsinogen. Pepsinogen, here you can see pepsinogen, is activated by hydrochloric acid and becomes pepsin. And pepsin is a protease. What does protease do? What does it destroy? Proteins, yep. So pepsin destroys proteins. Does that make sense? So far we covered mucous cells, we covered parietal cells, we covered chief cells, mucous neck cells, which are located at the entrance to the gastric glands, produces mucus that is fairly thin and acidic. We do not know what is the role of that mucus in digestion. Make sense? I mean, it doesn't for me, really, but I think that's a beauty and the curse of physiology. Like, you see something, and it's there, and it may not make sense to you from a logical standpoint, but it's there. And the organism that has it doesn't die. So we have it. Why? Who knows? But we have it. Does that make sense so far? Finally, enteroendocrine cells. Here in this image, they're shown in green. Entero means digestive system. Endocrine means they produce what? Hormones. They produce hormones. Different hormones. They produce serotonin, produce histamine, somatostatin. We'll talk about them in time. But the point is, in the mucosa of the stomach, there are cells that release hormones. Does that make sense? Now, which two cells, two types, would be critical for digestive process itself, for breakdown of food? Which two cell types would be critical for food breakdown, just food breakdown directly, for chemical digestion? Parietal cells and chief cells. Everybody agrees? They produce the digestive components. Now, if you would look at the distribution of the cells and, digestive activities across stomach, here's what you're going to see. I created some kind of a weird image down in the right hand side. First, cardia and pylorus. What happens at cardia here? Food enters the stomach. Something else substantial? No. Food enters the stomach. What happens here? The pyloric canal. So again, food leaves the stomach, right, to the intestines. So we have entrance and exit. Nothing substantial is going on there. The main type of cells you're going to find in those regions of the stomach are mucus cells. Correct? You have mucus here and there that simply protects the epithelium. That's it. No real digestion. We're good? Got it? Pyloric antrum. The green square here. Pyloric antrum has a fair amount of enteroendocrine cells. Why do you think? What's the function of the hormones that are produced by the stomach? You don't know about them, but just in general, what can be the function of the hormones produced by the stomach? What would they regulate? To some extent, it's a good one, yes. But mostly, say again? Digestion. Digestion. They would regulate digestion. Either stomach digestion or activities down the road. Does that make sense? Now think about this. This is a control center, sort of. When food gets to the pyloric antrum, this green box, let's go sort of, okay, we've got food here. We need to change digestive activity of the stomach a certain way. We need to change digestive activity of duodenum a certain way, large intestine a certain way, and so on and so forth. Does that make sense? If there's no food, I mean, that's it. Or if it doesn't reach the antrum yet, then there is no point to send any signals downstream. Does it make sense? That's why neuroendocrine cells that produce gastric. Finally, fundus and the body. I mean, it's kind of a lousy representation, but you get a gist, right? So that part of the stomach, fundus and the body. These parts contain cells that produce real digestive gastric juice. Okay? Hydrochloric acid, pepsin, because those parts is where the most of the digestion occurs. Does that make sense? Got it? We cool? One thing that I forgot, I'm going to mention one thing, just show it's awesome, and probably I'll just pull out some microscopes. What I wanted to say. Oh, yeah. That thing. Picture in the right bottom side. It's a really cool picture. It's a micrograph of the junction between the esophagus and the stomach. This is esophageal epithelium. And look at the type of epithelium. It's a classic picture of stratified squamous epithelium. Multiple layers. That's basal layer in the bottom, and then multiple layers. And then when esophagus ends and the stomach starts, immediately, right away, you go with columnar. Isn't that awesome? Just, there's no transition. Just one stops, another starts. Does that make sense? So on that optimistic note, we're going to